How's it going, everyone? This is the Nips and Sips podcast show. Feature me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today, we're going to be talking about another podcast that recently came out a couple months ago. A very interesting topic between Adam Meakins, who I think we've referenced a couple times on this show. Very big proponent of not doing manual therapy in physio or physical therapy, and Chad Cook, who's would say one of our forefathers and leading educators and researchers in manual therapy. But before we get into that discussion, Brandon, how's it going?
Going well, Jared. Thanks for the lovely intro as always. Definitely excited to kind of talk about this podcast, which we've talked about these two individuals probably in passing in other episodes. I know I had sent out an email blast on our IOSMT site and business where we do our continuing education for our audience and members to just kind of, if they're interested, listen to it and hopefully develop, their own opinions and thoughts and, kind of just present the what's out there, and hopefully people can kind of sift through the information and come out better on the other side. And I think it's really more of a reflection. So, as we get back into the swing of things here, we thought it would be good to just kind of give our thoughts and maybe some key things that stood out on our end. I think it's no surprise what side of the coin we will be on, but maybe it might surprise you with some of our takes here. So what's good on your end? What drink you have today?
Oh yeah. So for drink today, obviously I usually get beer. One of these days I will get to the whiskey and the bourbon that I have. But the wife got me, I forget for what holiday, I get now a beer of the month club, as if I didn't have enough beer in my life. So I just, nice surprise, once a month get a box of beer outside my door. It's a nice little present. So I have Double Mountain Vaporizer, which I believe is in Colorado, Hood River, Oregon, sorry, which I actually went and visited with my brother, so that was especially cool. This is a dry hopped pale ale. This is actually one of my favorite beers, so I've had it like 3 or 4 months, this beer month club, and it comes with 4 beers each time. This goes down as one of my favorites. I'm already gonna give it an 8.5 on because I already had 2 of them. But drinking out of my Village Idiot Brewing Co. That's in Mount Holly, New Jersey, really good brewery. So hopefully we're vaporizing. That's the beer's name. Some Village Idiots maybe in this conversation. But no, I actually thought it was a good conversation. Again, we're obviously biased towards maybe one of the presenters, but I thought it was a good discussion. But Brandon, what about you? What are you drinking?
So going with another beer here today.
2 in a row.
It's not because I'm switching to beer. I actually just had a birthday earlier this week, and my friend and coworker Marta had gotten this for me for my birthday. So it's Gray Sail Brewing of Rhode Island. It's called Dave's Coffee Stout. Knowing that I don't like beers, but I am getting to the stouts and porters. She had gotten this. So I actually had one on my birthday. I went home and cracked it open. So I do have a rating, though my rating scale isn't as refined as yours and your esteemed palate that you have here. But I'm trying to do my best Jeremy rendition here. I'm pouring it in front of the camera for everybody. I'll give my rating here in a second. It's trying to build this up. I guess I should read it. You like to read your ingredients. It's an American stout infused with a blend of Ethiopian and Brazilian coffee, roasted and blended here in Rhode Island. So that's a little description there. Did I do that right, Jeremy?
Oh, you did. Spot on.
So I have my lovely Axe and Arrow mug here, or cup, that I bought. I love here.
I'm gonna have to donate you some of my if you get into beer, I'll have to give you some of my glasses.
Yeah, you have like 600.
Yeah.
Doesn't even, like, you open up Jeremy's cabinet in his kitchen and they literally start to fall on you. You sit there catching them.
Now we can't officially put it in the cabinets anymore, so it's just like the ones I'm using are just kind of waiting in queue for me to pull some different ones, and becoming a mess. The tradition die.
got quite the collection there. This is good. I like it. I don't know if I like it more than the last week. The what was that one? The hazelnut one. I forget the name of it. What's it called?
Hardwired.
Hardwire. There you go. not to give too high of a scorings just because I want to leave some room for growth. I'm going to give it a 7.8. I gave a Hardwire an 8. I definitely like that one more. But this is not too far behind here.
Nice.
Maybe in a few, as my palate changes, I might come back and reorder or re-rank these. But right now, I'll give it a 7.8. It's a good coffee, good coffee flavored stout. So that's what I'm going with. So thank you, Marta.
There we go. And happy birthday to Dr. Cruz.
Thank you.
Last.
Turning 35.
Oh, wow.
From audience out there.
There you go. That's the prime of your life, right?
There we go. Right in the thick of it. Actually, prime of the life, but if we're looking at athletics, I'm past the hill here.
When would you say your prime was, athletically speaking?
Oh, well, they say it's from like 25 to or 23 to about 32. I'd say mine was probably about 18 to about 28.
Okay.
And I'd say that's mainly because I just stopped playing and being as active because of school and work and starting in multiple businesses. And, that kind of takes a back seat. But, you asked me, I could still go out and hoop.
Yeah, no, crush your students in golf and basketball from what I heard recently.
From what you've heard, yes. We had a student. I had a student who was in his prime. He was 24, and I think I smoked in every activity that we did. But so maybe I still have it.
That's good. Me, I'm starting to play more basketball and soccer, and really starting to feel the little bit of a loss in the step. A little bit of quickness is starting to dissipate, but
you want to know where you feel it? You don't feel it against people around your age group. Like you still a relative and what you had then, like, yeah, I still got it. But then you go up against like that 22-year-old or 18-year-old that just has a motor for days. And it's like, all right, yeah, this is different.
That was last night for us. We got either 4-1 or 5-1. It wasn't pretty, but pretty sure they all just recently graduated high school. So they mopped up on us pretty bad, but
this is where we join the 35 and older leagues. Well, I do. I know you're not 35
yet. that league wasn't open yet, so hopefully in a couple of years for me. But
right. So let's kind of jump in here on just the two presenters, and if any of you guys out there have listened to it, and if you haven't listened to it, what's that gentleman's name? Jared Powell, is that correct?
Powell, big shoulder guy from Australia, I believe.
So he did a great job in introducing both of those gentlemen, and I have some things that kind of stood out to me in the intro. What were some things that stood before I go? What were some things that stood out to you within that intro?
Yes, obviously two very different career paths in the sense of between Adam, and whose most of his fame is obviously from Instagram and social media, and you get Chad Cook, who's I forget how many articles has he participated in. It was
300 or upwards of thereabouts.
Yeah, 50 of them specifically towards manual therapy. I think most of us know the cookbook of manual therapy and the orthopedic examination stuff that he's done. I know Adam does do some research here and there. But yeah, just two very different, I guess, career paths and those sort of things. Excellent, presenters and talkers. Really, it just from the get-go what their belief was. The first start was kind of like what they wanted to categorize or describe manual therapy was, fairly similar. I feel like they did have a lot of similar points throughout this, which is why I wanted to kind of talk about it. Initially going into this, I was very against Meakins, but I thought he brought up some valid points throughout. But the first part was just how would you define manual therapy? And for the most part, they were, they brought up similar points of applying some, hands-on techniques or hand-on application. Clearly, Meakins, belief of it was, all encompassing of like soft tissue, joint mobilizations, manipulations, dry needling, everything of that sorts, versus, Chad didn't really believe like dry needling was associated with manual therapy, but they did kind of agree on in that standpoint. I liked how Chad, which I think is the real benefit of manual therapy, believed it was also part of the assessment and examination process versus it seems, Meakins' idea or Adam's idea was it's purely a treatment sort of thing. And I think that in my experience now is manual therapy or these techniques that I learned from maybe manual therapy courses or residencies and fellowships is more value to me from an assessment or evaluative position versus just pure treatment. But what about you, Brandon?
Yeah, I think for me, going back to the beginning part is that the intro, and not to discredit anybody in their education or anything, but you have somebody in Chad Cook who is clearly a leader, and kind of backs it up with, he's spending time in the trenches. He's doing the work to put it, do hundreds of articles to try and better the profession and even just healthcare in general with, what's working, what doesn't work. Are we really truly reading the research the way it's supposed to be read? Are we just lumping things in together, or are we really trying to go through it with a fine tooth comb, or as he, I believe he referenced a point in the conversation, a rake, trying to comb your hair with a rake, where you're going to miss some things. So I really think, taking that extra step, which, because of, society, work demands, family life, social life, things like that. I don't know if, enough therapists have the time or drive, or I'm sure there's a few different reasons in there, have the ability to really take a step back and dive, a mile deep into a topic to understand the nitty gritty of it. Right. So you have somebody who has, has gone through, probably his master's at one point, then doctorate, and then PhD, and teaches courses, and is at a major university in Duke University, which is, one of the best in the country. And, someone of that caliber who's also presenting at, high esteem conferences and things like that. And then you have somebody who's basically just gained their notoriety off of social media and Instagram because you could say outlandish shit and get a bunch of followers. And that's not to say he doesn't make some valid points with what he says, or, taken away from what he has gone through in his experience as a clinician, because obviously that's where a lot of his viewpoint is. But, I guess my message to people out there, and it even comes to us, you and me are talking, we're leaders and, thought leaders, and try and push this profession forward in the ways that we can. What credibility do we have? I would say the same thing to Adam Meakins or anybody else out there that you find. On the one hand, the positive of the world that we live in today, the age of information, that you have everything on YouTube and social, Instagram, Facebook, TikTok, whatever platform you want. So you can get information like this, which is in some instances great. But on the other side, we are still a medical profession, and we still need to have some more roots in the traditional, academia and things, and not just finding people blindly because they say outlandish stuff on social media. The other day, I was told that he made a post of, should physios be called doctors? Should cowards be called doctors? And kind of poking that bear and getting a rise out of people that way. So are you just saying stuff? Is he just saying stuff just to get a rise out of people? Or, what are you trying to do? Are you really trying to push the needle forward in a productive way with some of the stuff that he says? So I'll leave it at that, because, preparing for this podcast, I did, watch some of his other stuff. And, I've been aware of him for a while, but I wanted to get a better understanding of where he's coming from prior to just coming in and saying he's wrong or right, and saying Chad's wrong or right. Obviously we have our our biases, which is fine because we're aware of our biases. But I think, as we get into this conversation, and I'll leave, I'll kind of start it off with this thought right here. For some reason in physical therapy, I think we're becoming more isolated, and we've kind of talked about this before. We have this top-down approach, of neuroscience and pain education or cognitive behavioral therapy, and taking the time to educate your patient or take a hands-off approach, with exercise or motor control and things like that. Or we have the manual therapy side of things, right? Or your bottom-up approach. And for some reason, we have these camps and this viewpoint of these two approaches being mutually exclusive. And clinicians can't use, both things together or all three things together, or whatever you consider top down versus bottom up, right? We have isolated these two as camps instead of let's bring these together and merge them and overlap them in our treatment. And I think that's where we really need to be going, instead of having these two camps of, the Chad Cooks versus the Adam Meakins, or, there's a like that's out there, the clinical athletes, who are in probably the camp of the Adam Meakins of the handoff approach and strength conditioning and things like that, or Squat University, which is fine. But then we have, the do manual therapy camps, the Chad Cooks, the AOMS, the residencies, and things like that. So, I think we need to start bringing these together. So I'll kind of hand it off to you with that before I go off on some more tangents.
No, I agree. And I mean, Chad Cook brought this up of how each one of them, whether it's exercise, can have an effect on even pain, even though it's not, been proven to be the case, is what, Chad and even Adam was admitting to. Education, and then, manual therapy. Why not get the effect from all of them? Why not build it? Let's say it makes it, one does, manual therapy, it makes a patient 20% better. All right, now we do exercise and that makes them 20% better. Then we reassure them, say they're going to be fine, and psychologically they get 20% better. So why not use them all, versus, solely keeping to one camp? And if you're really, doubting this, test it out yourself. That's what, stop trying to be so biased, play around with things. I think even Kyle's mentioned it, who's been on this show, Feldman. I've done a period of it where I haven't done manual therapy as much. And I, went back to it. I had a huge, and we talked about this in the previous episode as well, our pain science one, where I went really down the weeds of it because I saw there was a lot of benefit to it. But went down it probably too much and figured, all right, I can maybe just spend more of my time educating, then let's get them moving, moving. And, I found myself coming back to, manual therapy a lot for that, pain modulatory effect, which, Chad Cook mentioned before. That's what people are looking for. Again, at least in this society. But again, was it 1.4 billion, I think he mentioned, chronic pain. A lot of people are looking to have that pain changed in a natural, non-invasive, non-toxic way. So I mean, play around with it. I've again tried it. I've seen a resident of mine that was, he was a very, Brandon mentioned, a clinical athlete, a lot of squats. He considered himself a loading therapist, which always frustrates me when someone classifies themselves as a specific therapist. You're always a physical therapist. I treat sports individuals, but I'm a physical therapist. So I pull things from all the different paradigms of physical therapy. But that was his approach, and I'd be there with him. I'd let him to try to do his thing. I'm like, all right. And then I would try and do something, and the patient got better. Maybe it was because I was a teacher in that position, or just the watching, observing, and there's some alert to me. But, he was a doctor and that sort of stuff at the time. I don't know if it had much more of a grandiose effect for me. But, play around with it. If you're really a doubter, or if you consider yourself a loading therapist or a movement therapist or a manual therapist, play around with the other side, and see how better probably can be if you integrate multiple things at a time. But yeah, it's just some points based off of what Brandon was saying on that. I think that's where I think our best, perks of our profession really is. And Chad mentioned it as well. It's just like you talk to psychologists and they say we are in the position where we can perform, psychological based interventions and exercise, and throw in the third thing into that. We can provide some sort of pain modulatory, generally, in my experience, manual therapy. But if you want to try stem and all that sort of stuff, you can try it. I've since weeded it out because it just, at this point, patients can buy that sort of stuff at home. It's great. CVS has them now. We have complex units in Mark Pros. You can buy your own nice, hyper ice, heat and ice sort of stuff. So have them do it at home. They don't really need your skill for that sort of stuff.
So, Jay, I have a question for you. Do you feel all manual therapy is created equal? Because, and now, for those of you who don't know Chad Cook, or familiar with his research, I should say, and for the most part, it's geared towards the joint-based manual therapy, right? It's not really focusing on massage or trigger point or any A-stim, anything in that kind of camp, or even dry needling, if you want to consider that as manual therapy. Most of his research on the manual therapy side is more joint-based, right? Versus we have Adam Meakins, who just kind of wanted to just lump everything in one pot together. To me, they're not the same. Mm-hmm. Before I kind of go off on my points, what are your thoughts on that viewpoint? And can we help tease things out for our audience here on, should we hold the same weight on each technique or each camp within the manual therapy umbrella?
Yeah, no, absolutely not. And speaking of like research and that sort of stuff, I don't know if you guys saw when I shared the screen, Adam Meakins has had 7 contributions to PubMed. That's the search I used. And I think 5 of them were viewpoints, just viewpoints, not actual research. And I think the other one is just him refuting the shoulder symptom modification procedure by Jeremy Lewis. So it's not really a contribution. It's more just he didn't like the fact that it was a hands-on approach and kind of shot it down. But nonetheless, and then Chad Cook has over 300. Real
quick, not to cut you off, the big thing of that, like his is just, it's viewpoints, it's opinion based, and maybe he uses some articles to back that up. But then you have somebody on Chad Cook's end who is going through a vetted process, some rigorous trials with IRB boards and all that other stuff. And granted, there are limitations in every single study. I don't care if it's randomized control or systematic review or meta-analysis, or all the way down to the lowest level, which is expert opinion. Well, we could also talk about what does expert opinion mean? What do you need to satisfy the title of expert opinion? Do you need X amount of years practicing? Do you need X amount of followers on Instagram? Do you need X amount of extra training or credentials like OCSs and residencies and fellowships? Or PhDs, DCSs, whatever. What quantifies expert opinion? Right? I'm going to say just because you have 100,000 followers doesn't make you an expert. Mm-hmm. Call me a hater, whatever. That doesn't make you an expert. I think there needs to be, more substance to that. So just, you guys out there can make your own opinion on somebody who's gone through, the regs of an IRB review and the process of research and understanding it to the nitty gritty, well beyond, 99% of therapists or 98% of therapists. 1% of therapists probably have a really good understanding of it. And then you got that 0.001 or just, take it to the next level of the pros and cons and, the type 1s and type 2 errors and all the little intricacies that, are meant to show up on the research, but they don't make the final cut because it has to be narrowed down, and all these other things that are even well beyond what I know and probably what you knew, Jared. So I just wanted to say that in terms of what you were sharing with the screen and, levels of, Sackett and levels of research and things like that. So sorry about that.
No. I completely agree with you. And I feel like a lot, and I've been a little bit more critical of Instagram and that sort of stuff. And look at these people, hundreds of thousands of followers. And a lot of it's just, and to be honest, good camera skills and time to edit and put a couple exercises together, which wish I said I'd have more time to do. And I keep saying I got to do it, but I haven't. Chad Cook I don't think he even has a social media, or at least Instagram, because
I'll look it up right now. I think he's on the Twitter sphere. Let me look.
Twitter. But he's not like making like 5 slides of these exercises that you need to do because I'm a guru and I have 200,000 followers, or that sort of stuff, or bashing other people. So yeah, check Cook PT. Oh yeah, is he on Instagram? Was that
no? He's on Twitter.
Twitter.
He has 15,000 followers.
Yeah, because he's probably busy,
doing research versus Adam Meakins, who has 123,000 followers on Instagram.
Yeah, so that's a thing. And I still see some of these most popular ones, like some guy today recently, it was like pure for sciatic pain, it's because your piriformis pierces the sciatic nerve pierces through the piriformis, or it's because you have a herniated disc, and try and give exercises to that, and people are going to believe him and reading the comments are like, oh my god, thank you, and they're doing it because he has 300,000 followers. But yeah, I digress there. Hopefully we can provide better education out there and those sort of things, and we properly vet who we get our education from. But going back to your original question that we've kind of went off on a little bit tangent there, are all manual therapies created equal? No, I don't believe they are at all. Again, as I just mentioned before, I go through trial and error, self-reflective periods where I try some things out, play around with them. Now I've got a very good foundation, but I always leave a little period of experimental with all my patients. But I play around with, a soft tissue kind of group. When I took a dry needling class, did a little more dry needling, manipulations, mobilizations, and that sort of stuff. And obviously Adam believes anything, his viewpoint was anything that the therapist puts their hands on, I believe with the exception of palpation, was manual therapy.
Cueing, I believe, yeah.
I'm just an FYI for all you guys out there, I'm a level 2 Reiki person, one level away from master.
I did not know that. When did you do that?
One of my professors, I think she's director of the program, Elaine Bukowski, that was her big thing. She's a Reiki master, and she offered anybody to, if it was a weekend, of course, if we wanted to learn the Reiki, she'd teach a level 1 one day and level 2 the next day. And if we came back for another one, we'd be Reiki masters, which
3 days. You're a master in 3 days. Wow.
Master, or maybe the master was a whole weekend. I can't remember. But you're pretty much a second tier down or 1 tier down from a master for just being there for 2 days. And I just took it because why not learn something new? Have I tried to apply it? Yeah, very early on in my career. She even tried to present some research that supported it. It was like for oncology and that sort of stuff. Do I utilize it anymore? Not so much, or not at all. But I guess there's some components of hands-on with that, where you're putting your hands on the individual. Does that count? No, I don't think it does. Meakins himself, I saw on Physiogram. I'll give it credit. It was a pretty funny post, but it's pretty much manual therapy, and then he would just be like his face in bullshit, and it was showing all these little short clips of manual therapy.
That was a good one. I think the message behind that is true.
Yeah, but he's
largely
picking half of it was, people doing plunger stuff, where they literally take a plunger and then start jabbing you with a plunger, and then you intermix like dry needling, some other things, and that sort of stuff. And that's not how it should be. I get, maybe we need to start critiquing and trying to take those techniques out of our clinical care, because one, it just looks ridiculous. But who knows? Maybe that does work for somebody. Maybe they are confident. Maybe they developed enough therapeutic alliance that they can convince a patient that if I stick this plunger on you, it's going to make a big benefit for you. But that's his viewpoint, is all those sort of things that have been researched and have shown no real effectiveness are lumped in with things that we know have. And that's where mobilizations and manipulations come in. And I believe those should take the throne here of manual therapy and its effectiveness. We have research to back it up. Chad Cook has brought up the RCTs. We've brought up tons of them. There's countless of evidence for it. And, looking at Meakins and how, especially his posts against manual therapy, he cherry picks what he wants. Even the Bioloski article that we constantly reference in our courses and on this show, where it highlights the potential benefits of manual therapy, he uses the same articles to cherry pick it in the reverse effect. So, it's a matter of what you want to take from it and that sort of stuff. But again, I went through these periods where I've tested out different styles of manual therapy, and I found myself becoming more of a joint-based therapist because it was the most effective. But what about you there, Brandon?
Yeah, I don't think they're created equally, and I'll share some anecdotes in a second. But you just can't say that massage or deep pressure or ischemic release or trigger point release, whatever, keep going on, or pin down a muscle and have it move through an active range of motion or passive range of motion. I don't want to say the name because of licensing purposes, but we kind of figure out what that's about. It can be lumped in with a joint-based therapy, especially if you're looking at the proposed mechanisms, whether they're biomechanical or neurophysiological or placebo or whatever the case may be. They just affect different things. And I think part of Adam's frustration and pushback is against, and one of the key words he kept saying is the things that need to be done in a specific way, in a specific manner, with a specific dosage to yield a specific outcome. I can totally agree with that. Yep. But if you're throwing the baby out with the bathwater, you'll never come full circle or come to the other side of viewpoint or coin where, when we learn, even with joint-based, the stuff that we preach and like to do so much, when we first learn it, we're following how it was taught to us, the setup, the original forefathers. Oh, you should do it this way, you should do it that way. But then and this is the key part, as we've developed and progressed and developed clinical decision-making, which I think all of this comes down to clinical reasoning, decision-making, which I don't think is enough time is spent on that. And Chad Cook had said it, if not here, he said it in other conferences where I've heard him. It's not the skill of performing something, I'm paraphrasing here, but it's knowing when to do it and how to do it. Mm-hmm. So it's not the debate of whether these are interventions that work. They all work. Everything works. It's, are you doing it to the correct patient at the correct time, mm-hmm. right, in the correct manner, mm-hmm. right? Are you picking the most likely candidate? So can you, as a therapist, identify the person who's going to respond to said intervention, whether it is soft tissue or whether it is joint-based? But going back to it, I mean, you read enough of the research, a lot of the joint-based stuff, just has a greater carryover. And this kind of goes into a little bit of what Adam was saying, where he's like, we should just be diagnosticians and send people out. Well, I won't even go down that part. If we're just sending people out and going to, go to a massage therapist, go to a personal trainer, go to a, so-and-so, and we're just a spoke on a wheel. I've seen that. I've had people, you've had people, we've all had people go to another provider, go to a stretching place, right? They have these now. You can just go and get stretched out for half an hour, right? Which is to me a mockery of our profession and giving the wrong information to people out there who are in pain. And it's like, well, yeah, you're tight, but why are you tight? Yeah, you're in pain, but why are you in pain? I'm just giving you something palliative. Yes, you go get a massage, but are you getting a massage because you want to relax, or do you think it's therapeutic? Right? That's where we as a profession need to not dumb ourselves down, because we have that ability to screen things out and perform more of an evaluation, with our education now, to do that, and not just, be a spoke in a wheel, as he says, and just, triage people left and right. If that was the case, everybody who gets a massage would feel better. That's not the case. Yeah. People have gotten massages time after time after time. Maybe they feel better in the short term, and then they're still in my office. I manipulate them 2-3 sessions, couple with some exercises, as I was talking about before, combining bottom up and top down approaches, and in 3 visits they're better. So, and if you look at the research, you can't compare, that company that you press down on a muscle, a little pokey, right, as Adam would say, and you have them move through a range. A lot of times, at least in New Jersey anyway, it's not approved for CEUs. Why? Because to get approved for CEUs, you need to have research that backs up what you're doing. There's not that much research that's backing that up, and hence why it can't be approved for credits. But what it is, it's a money grab. And I think that's Adam's frustration, especially speaking to another individual who's my lamp just fell, who has spoken to him, because when I was a young clinician, I was, on Twitter and Instagram and trying to figure out who to follow. And I had asked him why is Adam so just anti-manual therapy? This guy's, wrong. He's an idiot, blah, blah. And, this individual was like, yeah, well, I spoke with him on the phone, because apparently they had some back and forth on Twitter. And, they got on the phone and kind of hashed some things out. And, one of Adam's thing is it's a money grab, which, to an extent, I totally understand, things like that, where to keep the credential, you have to go back every year and re-up, or just pay $1,000 or whatever the money is to keep the certificate. Yeah, at that point, that's a money grab. I totally agree with that. But then on the flip side, Adam goes and sells T-shirts for $30 a pop saying manual therapy sucks. So, you can't pick and choose what you want to be a money grab and what you don't.
Yeah. And then I've mentioned it before, is especially the non-manual therapists, which are especially popular on social media, it incentivizes them, because you can't teach manual therapy really on social media, or not being right there. I mean, we put up videos, but incentivize them is, trashing it. So you take a different approach that can be taught anywhere across the world, and give hundreds of people signing up for your stuff. So again, I think it incentivizes them to also not integrate it into their own practice approaches. But yeah, I mean, going off of what you were talking about in regards to the triage thing as well, and Adam brought up a point of like cost effectiveness. We're talking about money now. Is he's
well, saying, not even well. Pause. Not to cut you off, Jer. And this was brought up in the podcast. How are we quantifying cost of or effectiveness? Or I think, I'm sorry, you said cost effectiveness in the podcast. They had talked about low value versus high value. And then are we equating that to cost effectiveness, or are we creating that in another definition of some sort? So I just want to throw that out there as well.
Yeah.
So, yeah. Good. So we could start with the cost effectiveness. Definitely.
Yeah. And they were just saying, how is it, like Adam was making a point, it wasn't cost effective, it was low value. Care is manual therapy, and made the reference to McDonald's and that sort of stuff, as it's tasty, but you wouldn't want to recommend it to everybody, or we shouldn't as healthcare professionals. Think about it in the sense of, is it cost effective to really refer out to that many different individuals as well? Is it cost effective to refer to massage therapy, to a strength coach or a trainer or a psychologist. Why not? Why can't we be the ones that do it all there in one session? Get that summonation effect. We know manual therapy for the most part lasts anywhere from like 17 to 22 minutes, the effects of it from a neurophysiological standpoint. So capitalize on that. Chad mentioned it before, is like, it gives you the opportunity to move more or to move, take that and then add the education or the exercise in versus, all right, yeah, again, hour-long massage, and then I need you to schedule your personal training session right afterwards. And then right after that, you're going to go schedule your psychology appointment. You're going to have 3 hours spending on 4 different professionals now. And, it's going to cost you a lot more money. And time. 2 hours, right? Or let's say they're half-hour sessions, 2 hours. When we can do that all in realistically 30 to 45 minutes. You want to go into hour by all means. So if we're talking about a pure money standpoint, no, I think we are. And sometimes we do need to continue. I think for most neuromusculoskeletal cases, we should be the quarterbacks. We should be the ones that kind of refer to the spokes or whatever you want, however they phrased it. When it's needed, when it's more beyond what we need to do. All right, I'm doing maybe dry needling, but it's having an effect. Maybe I need to have that person go to acupuncture and do the whole thing for 20, 30 minutes or whatever it may be. Or I'm providing some cognitive behavioral therapy. It's getting some places, but there's some deeper, darker stuff that's not going to come out in a group setting with 3 other therapists and 5 other patients going around. This person needs some one-on-one time. Or maybe I'm doing some soft tissue. It's making some work, but an hour's worth would be more. Maybe I'll refer them out that way. But if we can give them a little, dose of each and then capitalize all of those in a session, I think that's where we can really make the most improvements from that multimodal effect. Yeah, Brandon, any thoughts with that? And I know you want to kind of talk about the differences there.
Yeah, I mean, before I get to the differences, I think it really comes down to the viewpoint. What intent are you trying to provide whatever intervention or treatment to your patient? Chad Cook had said that chiropractors have, or certain chiropractors have come and started to publish papers or viewpoints, recanting that their manipulations improve cancer and different diseases and things like that. Now that's a viewpoint, but if you take the manipulation itself in isolation, it's still has benefit to at least certain people. So it goes back to, are you applying said technique or intervention or treatment plan to the correct person at the correct time? Is it understanding that, somebody who has an 8 out of 10 pain might need some pain modulation, and what are your tools to get them to modulate other than educating them? Because that's not modulating them, right? And then educating them to get them to move better and trust themselves again, versus somebody comes in 1 out of 10 pain. Well, yeah, maybe manual therapy is not the thing. Maybe they don't need modulation. Maybe they need some education, some self-management things, and kind of understanding and trusting they can move again and having to move. So I really think, whether it's Adam or Chad or you and me, it's really understanding and being reflective in your practice patterns. Mm-hmm. I had, something I disagreed with Chad that he said is like and I'm all for, not having every patient have to see you, being okay to tell them, hey, I'm not the provider for you. But one of the things he said, like somebody came in with, wanted a rotated inotament, I think was the example, but whatever the case was. But, if that's what resonates with that person, and I was actually having this conversation yesterday with a fellow I'm training, like if the easier explanation for a patient to understand is them relating to something being out of place, and you just do whatever technique that helps and they think helps, right? Or that they're coming to see you for, and you do it, and it takes you, let's say, 5 minutes to do it. And then you're able to get them to do other things, and you're educating them and whatever. And You don't fear monger them where they need to come back 3 times a week for the rest of their life because it's going to slip out again. Mm-hmm. But if you kind of give them what they want, but also kind of do what you need to do as a provider, what's wrong with that?
Yeah.
Versus divorcing that patient because you as a clinician don't believe in it because of your ego or, you know, what you've been taught or whatever the case is. And then they're just going to go to the next guy down the road and get stuck into that cycle that you didn't want to be a part of, instead of trying to be a plug and, hey, I can spend 1 to 3 sessions with you. You're on your way. And guess what? And it's 6 months, 8 months, a year, it happens again. They come back to see you. And now you're that kind of primary care provider. What is wrong with that? And that was something in the podcast too, patient-centered care versus patient-focused care, and kind of that debate, you know, do we need to be inclusive with what they want and things like that? But, you know, if you have 100%, or if you have a whole pie and 7 of the 8 slices, you do what you need to do as a clinician based upon your training and experience and knowledge and research, and you give them 1 slice to appease the patient so they can buy in, what's wrong with that?
Or I think even in the sense of, yeah, so I get those patients, especially the classic leg length discrepancy, right? Or my hips are out of place. I feel like every runner I ever treat has their hips out of place. But nonetheless, use it as an opportunity to finally right the ship. Like, this person's probably been going to practitioners for however many years. I've had some people are like, listen, can't teach us old dog new tricks when it comes to their beliefs of certain things or what their needs are, but use it as an opportunity to actually start to educate them. And I try and use that, and I'll appease them. Again, patient expectation. Chad mentioned it numerous times during the podcast, is that is a strong predictor of, like, you know, outcomes and how well they do. And we should respect that. But yeah, so I'll do a technique, and then slowly with my education process, once I bought them in and once they believe that, wow, this person can help me or they're making the right decisions for me, then I'm using the education of, like, yeah, you know, just so you know, most people, they have one leg longer than the other. It's usually not a true anatomical deformity. And I'm splashing that in and trying to take away these fears that they have versus, you know, all right, I'm going to do it, treat them, and then, you know, they come back. I try and peel back some of the layers, and, you know, sometimes it works. Sometimes the people are just fixing. They're like, now I'm going to go I'm going to go to my other practitioner, chiropractor, wherever it may be, and I'm just stuck that way. But every couple of them, especially my older patients, and I say, yeah, physical therapy, chiropractic medicine, we sucked back then. Always say we sucked. Not to, you know, trash on our, you know, previous therapists or anything like that. But as a profession, we've grown. But I'll say, yeah, what we knew then is completely different from what we know now. We said that these things, like, yeah, leg length discrepancies or your pelvis was out of place and we have to put you back together. It's really not so much the case. Sometimes your back pain can be completely unrelated to your pelvis alignment. And more often than not, once they've already bought in and believe it, and they've heard other education from us, they start to believe it. So I use that personally as an opportunity to kind of get them on our side and, you know, help them down the road. And, you know, Adam made a point of, like, you know, the value of physical manual therapy and what it's doing for the long term, and saying, you know, is it, you know, lead to reliance and that sort of stuff, is what happens in the opposite if we don't apply that manual therapy and they start to get down that chronic pain because we fail to modulate it early enough. I get more of my patients coming from, you know, the mill style, you know, physical therapy place, because they're left to do exercises on their own. All right, so that's exercise right there. Clearly it didn't have a pain modulatory effect. Clearly it didn't get better because they eventually went to a second or third physical therapist or practitioner. And then what do I mostly do? Again, maybe I'm biased. Well, I'm educating, but I'm modulating their symptoms so I can get them out of that chronic pain route. So are we in chronic pain, or what? We have a chronic pain problem simply because we apply the right intervention at the right time for the right individual. So those are kind of some of my viewpoints of that.
Yeah, great points here. And I had some things to add to that, and I'm trying to, in my head, to make sure I address each of them here. One of them, with the kind of cost basis or the effectiveness, is what is it? What are we comparing high value versus low value treatment? There's this stigma that's becoming more and more prevalent out there that anything that's passive is low value. Why? A manipulation, a cervical manipulation. I'll even go higher. An AA and OA manipulation is probably the most skilled, or one of the most skilled things you can do as a therapist, right? If it wasn't skilled, every therapist coming out of entry-level PT school would be able to do it like that and do it well. So you can't say it's a low value intervention. It's clearly or you can't say it's an unskilled intervention. Pressy, rubby dubby, massage and stuff. Yeah, that's low value. A monkey could do that. Mm-hmm. Manipulating someone's OA, cervical spine, CT junction is not unskilled, and therefore it has value. We've seen it in the studies. I have the Hoving study. Let me pull that up for the audience, and we could post this on the when you post the video here. Can I share? Do I have access to share?
I just said multiple. I just said it.
All right, thanks. We have Hoving, and this is back in 2003 when you do this. It's more cost effective manual therapy than actually physiotherapy in general and GPs. This is for neck pain, at least. The reason why manual therapy is different, and this comes from conversations, obviously I've never practiced overseas, is that in overseas, in countries like Australia, New Zealand, things like that, manual therapy is an actual, extra step up, more education and things like that, versus a traditional physiotherapist, which is just exercise, right? I don't know if that applies to the UK, so maybe that's where Adam's viewpoint is coming. He's in a different country and we're here in America. But when you compare physiotherapy, which is traditionally considered exercise and education, versus manual therapy and a general practitioner, we have the better outcomes. All right. It's more cost effective because it takes less visits. But you talk about what Chad talks about, it's better than surgery and injections. Okay. Beyond that, it's better than, like you said, supervised exercise, unsupervised exercise, home exercise programs. And I believe there's one other thing. Did I write it down? Oh, and cognitive behavioral therapy. Mm-hmm. Right. So for certain areas, certain conditions may be able to be resolved with general exercise and education, maybe like chronic non-specific low back pain, or just non-specific low back pain in general. Maybe something like the shoulder or the neck or tennis elbow may need to have actual a true intervention that is specific. Mm-hmm. So I think, we need to have that understanding. There was something else you had mentioned that I'm kind of blanking on right now, but sorry guys. We tend to go off on tangents and can't always remember everything. So
it never helps, really.
Yeah.
Good for Gab, but not for recall.
So yeah, good for Gab in there.
Yeah. The other thing, I guess what I mentioned was just like, long-term, that sort of stuff. But
I will say this, Adam, going through some of his posts and listening to some of, his other podcasts or lectures or whatever, he's doing a great job in terms of hopefully getting clinicians to think, and not just going with the status quo or the new hot trend that's out there. Like you said, that bullshit post. Like, yeah, as clinicians, we should take a step back and understand, like, am I doing a good job? Is this intervention needed for this person? Is this intervention just needed in general? Is this just a new hot topic and trend? But what I don't want the audience, our millions and millions of followers that we have, my little rock reference there. What I don't want them is to throw the baby out with the bathwater. And just because said individual says manual therapy works, to do it, or because somebody says manual therapy doesn't work, don't do it, or insert said intervention there. We should be, I think you said it earlier, vetting things a little bit better as a clinician, especially a doctorate level clinician as well.
Because it's all based off of, your area, your people, your your competition, everything. So maybe people in South Jersey need more manual therapy versus people in Montana, they just need to be told to move, or I don't know, I'm picking on Montana, but it's based off a lot of things. It's based off of your persona and your ability to be, give a good therapeutic alliance. So, play around with it, but just don't stick to just one thing. But that's a general theme of a lot of the conversations that we have here. I think he talked about it at one point. It was like, what do you say, putting the patient in the driver's seat and that sort of stuff. When he's talking about like, here's your 8 options, pick whatever one works for you.
Mm-hmm. That was the patient-centered care. And are we taking that definition out of context?
And I don't have that experience. And I think that's probably because of the population we see and I think my student mentioned that she's just like, they don't ever argue or suggest anything to you. I'm like looking at the clinicians, I don't think they do that to any of our clinicians in the clinic. It's one, we're highly direct access, and 2, it's just, I believe, how we convey ourselves as, and we're not saying we're experts, but that we're, we have education and we try and spread that knowledge to the patient and that sort of stuff, that they don't ever like, oh, I want to do this, I want STEM, or I want this and that. So I don't ever get the, here's your smorgasbord, let's, have at it. And I think that's really, based off of, how you convey yourself as a PT. If you really dive into like experimenting with things and really pushing yourself to find the next, best way, the fastest way to fix a patient, patients will pick up on that and they won't need to suggest, I need this and I need that. You're going to know what to provide for them. They'll have the confidence to do it, they'll have the confidence in you that you'll do that for them, if that makes any sense. But see, they pulled up an article, that'll end my small rant there.
Oh, and also I will say this, for not to say, not for better or for worse, you also have a younger patient population, and couple that with, they're tend to be active and athletes, and the direct access, like they're coming to you specifically for said reason. So they're going to come, they're going to most likely listen to you, especially off the rip. Maybe down the line, they might start asking some questions where then maybe you have to lay out some things. But, I think age is a reason too. You have somebody who's, 20 years old, 21 years old versus somebody who's 50 and kind of a little jaded by life, maybe, might. But, you also have to be able to understand how to relate to people in different age groups and camps and things as well, which comes down to our ability to communicate and educate our patients, or de-educate to re-educate them. The big thing here is communication. I just wanted to show this article here, though, of 50 to 70% of people don't adhere to their home exercise program. Right. So, self-management is only a tool. Oh, that's what it was. So you were talked about, doing a technique to somebody, right? And, de-educating to re-educate them. But it's not even that. It's, you can do a technique to that patient and use a leg length discrepancy, right? All right, I'm doing this for you now, or for the next 2 or 3 sessions. I can teach you how to do this for yourself, so you can manage this most days of the year. And maybe you only need to come in, a couple times just for a check-in or something else, but you don't have to come in 3 times a week for the rest of your life, right? That's what I want to talk about. Like, we can use, and this goes on the clinician, and you're talking about, those mill places that can, they're seeing somebody and they have to have their patient manage on their own, basically, with their exercises, which to an extent is good, but we're seeing that patients, or people in general, I shouldn't say patients, people in general, for a large part, just don't want to exercise. I mean, how many times have we had patients be like, what's one thing I can do so this doesn't happen again? And if it involves exercising, they're like, well, what's something else? Mm-hmm. No, you asked for the one thing, I'm giving it to you. You just don't want to do it. And that kind of goes into the, what Chad Cook was saying, like, whether it's manual therapy or exercise, physical therapy is such a small percent of our impact on a patient's life, socially, socioeconomically, psychosocially. Like, there are bigger things at play to get the person to have to change a lifestyle so they don't constantly come in. Not even a physical therapy. You could talk about just the medical system in general. But going back to that, therapists should be able to understand, multiple different ways to teach a patient to do a self-mobilization or a self-exercise or self-corrective technique or whatever lingo or terminology you want to use. So, hey, I'm doing this passively to you, but there's a way you can do it yourself, and I'll show you that.
Absolutely.
So now you're getting that patient involved and active in their own treatment and plan of care. So it's not completely a passive modality in treatment. This works. We know it works. You like it. Let me show you how you can do it yourself.
And then,
so that's that topic. Here's an article that just shows that most people don't do their home exercise program. So we can probably get rid of that. And, we've talked about it in episodes. I'm giving people 1 to 3 things to do, because anything more than that's asking for too much.
I treat an active population, and they'll still go to the gym, and they'll have the time to go to the gym, and they still don't want to do their exercise. I'm like, all right, so you hit the gym. Now you're like, did you throw this in part of your warm up? They're like, sometimes. I'm like, I don't get it. You have the time to work out, so it's not a time thing. It's just, they see the value and they get better, and they're like, oh, this and that. But it's a mindset. It's like homework. No one liked to do homework as a kid. So what you expect them that they're going to do as an adult when they have to take care of like 3 or 4 kids, they have to go work full time. It's not on the top of their mind. I think telehealth helped me see that. It's just like being inside people's homes, like nothing's getting done. Once you're home, nothing gets done. Like you got cats coming around, messing up the video feed. You got dogs, you got kids asking questions in the middle of a session. So just, not kidding yourself in the sense that they're not going to get as much of it done as you can. Just to top off what Brandon says, I agree. Every time I do a manual therapy intervention, I'm like, here's something that, you can do on your own that's going to simulate exactly what I did. And then I top it off. I'm like, a lot of the times we're talking about natural, progression of healing and that sort of stuff. I'll say, you will probably get better if we weren't to do anything more than we did today or anything at all. I'm just here to speed up the process if you want to. And that's it. And that's what we do. We're just here to speed things up. Hopefully they don't go down that chronic pain route. And that's it. It's just like, I don't try and kid them saying I'm here to fix them because I did a technique. One, I did a technique to help them within the session. So maybe they have increased capacity and threshold to do more, to psychologically make them feel better. Like, shit, I could not even squat. And now I'm doing a, goblet squat or a front squat without pain within a 20-minute period. He gave me a tool to do by myself. And then on top of that, he said, I'll probably get better on, just naturally. So I like to try and tie that all in together, just to, again, further empower the patient and that sort of stuff versus, well, again, what makes Adam frustrated is that the gurus and the egoisms of manual therapy, especially old and even currently, is that I'm here to fix you. And I don't agree with that, with when people do that. I always try and take away my manual therapy as I'm doing it, just for the fear that people do believe it. They're like, oh man, Jeremy's the one who fixed me and that sort of stuff. I'm like, yeah, you fixed yourself. I'm just here to kind of push you along.
Last thing I'll say, and then we kind of wrap up, as hopefully we have helped restored balance to the physical therapy universe. When it comes to, hold on one second. I want to kind of phrase this here.
Look at that thought right there. This is genuine live action, people.
What was I going to say? Now I just totally forgot everything.
Maybe you need more sip of your beer there. Hope.
No, I'm actually all out. Maybe that's the problem. What was I going to say? Might have to cut this part out, Jay.
It's original. Well, what do you think? Because sometimes it.
What were you just talking about?
I'm gonna just.
It was a point off of.
It's a lot of points there.
I don't know. Whatever. We should probably just end the show.
Yeah. Oh,
I'm sure it'll come up some other time. Or if I remember, I'll text you. You put it in the thread or something.
Yeah. I was gonna make a point, and then maybe that'll kind of stir some things.
Okay.
At the very end, it was a joke, of course, but Adam made his point of like, or in order to avoid pain, you need to be, not have a shitty job, not have kids, not be a single mom, be rich, all that sort of stuff. And there's some truths to that. But are we like dooming everyone who doesn't live in that? And I think most of the world isn't that lifestyle where they're very rich and got butlers taking care of their kids and that sort of stuff. And personally, I've treated very rich people and that sort of stuff, and they have pain just as much as your poor people or that sort of stuff. Why are we like kind of dooming them with just like, oh, you'll get better on your own? Like, why can't we help those? So that was my final point, and that is, we're here to help everyone, and here to speed up the process. And unfortunately, people don't know that they can naturally recover as much as they can, or the individuals that didn't naturally recover, what's the missing link? Especially again, my population, they're active, so you can't even throw in, they need to be more active and that sort of stuff. Most of my people have nutritionists and that sort of stuff, so they're eating right. Maybe some people need to work on sleep. Stress levels, let's face it, we're adults, we all have stress. You have to address them to each individual, but there is some sort of missing component there if they've already went down chronic pain. Yeah, I tell my students, we get too much credit for some of these acute care patients that within the end of the week they're feeling 100%. Well, it's probably going to happen anyways. We just look a lot better than we did. But again, what about those chronic pain patients? And I would say, manual therapy does help those individuals out. So that's my last closing thoughts there. I hope it did stir up anything there.
It did. I remember what I was gonna say. My man.
Thank you.
Meakins made a point, and this is not just Meakins. I mean, we dealt with this in residency, when it comes to outcomes. And I'm glad Chad pointed out, he's like, a lot of these outcome measures don't actually measure what we think they're measuring. But Adam brought up a point like, manual therapists, again, that big pot that he just lumped everything out into, are not cost effective because around him they're charging X amount of dollars. Let's just say they're charging, I don't know, $100, $150. If somebody's willing to pay that because they perceive value in that, what's wrong with that? Two, like, we do this to ourselves. We're like the only profession that or job that we want to get people better and never see them again.
Get rid of business.
Right? Like, that's not a business. Like, I'm sorry, Amazon makes their money because you keep ordering stuff from them every single day. And what's up?
The one-click thing, they make it easier.
Yeah, one-click thing. Things are now coming to you, in an hour. Forget 2-day shipping, an hour shipping. What's wrong with us seeing somebody for our knowledge and expertise? Mm-hmm. Yeah, maybe it's me performing a manipulation and them paying us $100, $200, whatever the number is, $75. I don't know. What's wrong with somebody seeing us and paying us for that for, a handful of sessions, 2 handful of sessions versus the alternative, which is them, being chronically depressed or stressed or anxious, or them getting opioids or other medication that cost hundreds of thousands of dollars, but you don't see it because it's funneled through insurance, which is a big racket in itself. Granted, Adam's in, a universal healthcare, so that might be a little different. I'm not sure what he's seeing, but why do we feel bad as a professional, at least in the US, that it took us 5 sessions to treat somebody instead of 1, or 12 sessions to treat somebody instead of 8? Like, I remember I had a mentor at Temple's program, and she ridiculed me. I thought I was doing a good job, less than a year out, getting people better in 5 sessions and 3 sessions. And she was just like, no, like one needs to be your number. Mm-hmm. I drank that Kool-Aid, at first, or tried to drink that Kool-Aid. And, years later, I look back and I'm like, why, I understand we shouldn't be seeing somebody 100 sessions for one diagnosis, but, there has to be some medium. We shouldn't feel bad about us providing education and our skill set and our knowledge to somebody who needs it. And if that takes 1 session, 5 sessions, 15 sessions, why do we feel bad about that? Mm-hmm. And I find this over and over again in our profession of, we need to empower people. Yes, we do. But, we also we can't chop ourselves at the knees either. We are a profession. We do need to, have income.
Yeah. And then on top of that, if you go down the pain route or pain science route and all that sort of stuff, kind of behavioral therapy and all that sort of stuff is, they talk about, stuff about you time, doing stuff for yourself as a person. Yeah. Me personally, my wife and I, we get, couples massage or, every couple months or something like that. It's my way of breaking up the stress of the world and that sort of stuff and getting away, wherever it may be. Why not go to a physical therapist and get manual therapy and talk about some things and recent aches or pains and get some education there? Why can't we be that? Why does it have to be, Adam made a good point of, at least with the triage thing, is it's there is no discharge. It's we're following up with people, but why can't we follow them up with the whole package? Why can't they schedule once or twice a month and we're just making sure that they're mentally right, physically feeling well, and that will lead to them being active and doing things that are better for their physical and mental well-being. I'm going to the gym regularly because I'm not in as much pain, or giving me confidence to do these sort of things. So why is that such an issue? I think we're bastardized by insurances and authorizations. We have to get things done by this sort of time, and we're under those constraints. But again, maybe as this profession moves forward and we're getting away from that is a model we should probably adopt. Become that true family physical therapist and that sort of stuff, and see our people regularly. I bring up some stuff about, old Chinese medicine was the doctor used to get paid regularly, monthly, by all his clients until they got sick. And when they got sick, that's when the payment stopped, and then incentivized them to go help them and then get the payments again. So I think that's a great model, in all honesty. You have your family physical therapist, whoever else you want on your team, and their job is to keep you, mentally and physically well, to keep being active, so you're, mentally and physically well. So that's my last little rant. But,
awesome.
Well,
we'll wrap up with that.
Closing remarks, schedules, and all that sort of stuff there, Brandon. And
I'll do the wrap up for the courses. We have 4 public courses coming up this fall. Cervico-thoracic management in September at my location in North Jersey at Pursue Physical Therapy. We have a lumbo-pelvic management down south in October at Jeremy's location at Trifecta Therapeutics. We're back in November for a 1-day extremity HVLA course, and then our big banger, our big course is spinal manipulation in the beginning of December. It's Jeremy doing his little self-manipulation. We do have 2 private courses. If you guys do have any interest in that, email me or DM me, and we'll see if we can squeeze you in, depending on how many seats are available. I will say right now we're actually on one of the courses are pretty full already. So, but any interest, just email me or Jeremy, and we'll get back to you. With that, we also have our manual therapy mentorship. It's called manual therapy, but obviously we talk about a lot of different things. So if you guys are interested in joining that and getting some more guidance and mentorship, please, email us and we could set you up with enrolling in that. And then we also have our video library, which is a monthly thing. If you guys are interested, can hop in on that, which has over, at this point, what are we at, 140 plus techniques of, basically the whole body. which we're going to be adding exercise component to as well. So I think that's all I have for us today. Jeremy, you got anything else, or
that's all. Thanks for tuning in. We'll put the link to the other podcasts up, and thanks for listening in, and cheers, everybody.
Cheers, guys.